ophthalmology, which is again a very sought after branch in for post graduation, and she has done her MS from Maulana Azad Medical College, Delhi. So apart from this excellent medical career, she has launched one website giving health advice, and which is www.grvarsha.com.
I think mute everyone. Mute
I'll
everyone.
mute everyone.
Lot
Yeah.
of disturbance. Lot of disturbance.
So, friends, I hope you can hear me. Yes. So, she has launched this portal, DR Varsha, and through which she gives these solutions and Dr. Varsha's health solutions. So, she is practicing this family medicine, and in which she is an authority, and she is expert on the National Health Authority of India, and in which she is an expert in the medical cell of the National Health Authority. And her consultation portal, it is giving free medical advice for COVID related ailments to around 10,000 persons per month. So imagine the social and humanitarian work she's doing. And then she's a speaker, she's a writer, she has come on many radio shows, many television shows, and she has 20 years of experience, of clinical experience in medical and hospitals. And apart from that, she has got research liking also, and she has got substantial work in medical research as well as pharma research. So, being PhD from IIT, this is a topic which is very close to my heart. And she has published more than 40 papers in peer-reviewed journals, and those papers which are illustrious papers. As I told you, every paragraph I can spend 1 hour. So all those papers are also there, and I think you should know the papers also, particularly the professionals. And apart from this professional success, she is very successful in cultural activities also. As you know, she is a very good singer, and one song about Corona, मेरे ख्याल से Corona को हराना है, right? So this song she has written, she has composed, as well as she has sung. So you can imagine the versatility of the talent she has. Not only music, but in case of yoga also, she has come out with one video of spirit of yoga, and which she has sung along with very renowned singer Hariharan. So, friends, we have got a very excellent speaker in Dr. Varsha Narayan, and so I know you are very eager to listen to her and not to me. So, without wasting any time, I request Dr. Varsha Narayanan to go ahead with a talk on again very important topic of COVID, how to take care, home care of COVID patients, and about awareness about black fungus. Now we are reading every day. There's some state governments have declared it black fungus as an epidemic. So what an excellent topic we have at this current scenario. So Dr. Varsha, go ahead, please. So I will unmute you, and then you can unmute yourself, and I will make you co-host so that you can share your slides.
Thank you so much, Milinji, President. I think this was a wonderful and very inspiring introduction to me also. And at this moment, the only introduction that I want to give of myself is that I'm a doctor in service of humanity, and that is what is the need of the hour, as you all know. So today, I'm sure all of you must be thinking that we are hearing so much of COVID on TV. We are reading only COVID in the newspaper. Kash, kuch aur hota sunne ko aaj meeting mein. Again, COVID in the meeting. So, I want to start with that little apology that I'm not, I'm coming and speaking to you about COVID, which has been bombarded to you from all directions. But the whole idea of coming here today is that to share with you the experience and learnings that have happened over the last 1 month, where I have been able to treat several patients in home care. And this is not just my experience and learning, but it is a group experience and learning which has come about because of being a part of the Mumbai Mission 2021 COVID group, or being in the medical cell of the NHA. So I would like to just, share this group experience and learnings that have happened in the last 1 month of the surge, the second wave that we've seen with COVID in India. And of course, touch upon the black fungus, what is the scare and what is the awareness required and what we can really do at our level about it. So I think I'll just share my screen. So just give me 1 second. Okay. So is the screen visible?
Yes.
Okay. So I'll start with the important points. Should I start?
Yes.
Daksha ji? Yeah, okay. So I'll start with the important points and health tips as far as COVID home care is concerned. So the first learning that has happened, or the first experience that I want to share with you in this regard, is this whole question of, do I have COVID? So there has been a lot of confusion that I have seen, even at the doctor's level and the patient's level. And finally, we had to come across with certain parameters to define if a person has COVID or not. Now we all have been using the RT-PCR test. Now the rapid antigen, what we call the RAT test, is also available. It's available as a home testing now in the form of a small kit which has been launched by Mylan. And we even have RT-PCR, which can be done by goggles now. That has also been approved by the ICMR. So, of course, we all know that if you have an RT-PCR report or a RAT positive report, it is certainly a case of COVID. But the whole confusion happens is when the RT-PCR or the RAT is negative or is pending. That is also a problem. The report sometimes for the RT-PCR takes 3 to 4 days, and the patient is wondering what to do. Is it COVID? Is it not? Shall we start treatment? What to do? And the symptoms are present. So in this case, we as a medical community are working with the following in mind. Now, you see some symptoms which I have enclosed in a red box. Now, if these symptoms are present, now fever, cough, sore throat is characteristic. The loss of smell and taste is almost as good as an RT-PCR now, according to us. And of course, shortness of breath is a very, very big red flag. So if these signs are present, whether the test comes positive or whether the test has come, it's pending, we treat the patient as COVID, given the time of a second surge, a second wave pandemic. So that is the first thing to be remembered. Just because a report is negative, but you have these characteristic signs, we have to consider this as a COVID case. That's the first point. Now, what happens if you don't have these typical symptoms? That is also being seen in this epidemic, that a lot of vague symptoms are there. Somebody has a persistent headache or just body ache, tiredness, some red eyes. We had a couple of cases, a little indigestion, more gastrointestinal complaints. Now, in such a case, if there is another person in the household who is also suffering from COVID or is diagnosed positive COVID, we will consider you also a case of COVID. Even though you don't have the classic symptoms, but you have some symptoms and there is a household positive member or a close contact, so we will have to take you as a COVID case. Now, of course, there are patients who have very severe symptoms. So if there is breathlessness and still an RT-PCR came negative, that's when an HRCT gets advised. Or if the symptoms are very severe, the cough is full of phlegm, fever is extremely high, at that time we actually follow to advise for a high resolution CT scan of the chest, and that is almost confirmatory, even if the RT-PCR is negative. So if we see typical changes, we can not only confirm COVID, but we can also take a decision whether to hospitalize the patient or not immediately. So this is what is important. Why I'm stressing about this is that we had experience with some cases where the entire family had mild symptoms, but only one or two of them actually tested positive on the RT-PCR and one or two others tested negative, especially the young lot or people who had very, very mild symptoms. And because they tested negative, they were sent off to some other house saying, let's, safeguard them. We can isolate here and we can send these two negative people of the household somewhere else. And subsequently, they went to other households, their symptoms became more prominent, and then they infected those people as well. So this is something that should never be done. If there is one positive member in the family, nobody from that house should leave, no matter what is the RT-PCR report. And all of them should be treated as COVID positive or suspect COVID and treated as such. So this was the important point to emphasize, which we have learned. And also it's very important to mark the first day of illness, because the whole way in which COVID is treated, predictions are made about how the disease will progress, and also the treatment which we decide in terms of antivirals or when to use other medicines is dependent on that first day of illness. And we have had this interesting experience that most people either forget what the first day of illness is, or what they tell you, I have been feeling unwell since yesterday. And then when we probe, we find that these symptoms were happening for the past 4 days, 5 days. And by the time their PCR report comes, they're already into the second week of illness. And if we don't know that, we are treating them as if they are in the first week of illness or the initial days, and the whole treatment and monitoring system changes. So always knowing when your symptoms started, that is the day one, if you're symptomatic. If you're incidentally tested for COVID because other family members were positive or you were traveling or it was a requirement, then the day the swab sample was given is taken as day one. So this day one is very important when we are treating COVID. So going further, deciding on home care. Now, there are a small set of patients, I would say around less than 10%, who right in the beginning come with breathlessness or the oxygen is dipping below 94. Now, these are the patients who would need immediate hospitalization. That's when we do an HRCT and we are able to say how severe the lung damage is. So there is the small subset which is severe right from the start and we have to hospitalize them. But more than 90% manifest without any breathlessness, and their oxygen saturation is maintained above 94 comfortably. So these are the patients who can be treated in home care. There are also a couple of patients who are very sick. They may not have breathlessness, but they may be very sick, mentally disoriented, extreme weakness, not able to eat orally or take any tablets orally. We prefer to hospitalize such patients also from the start. But otherwise, most people are treated in home care, which I hope is a good news for all of you, because we have seen most of them to recover without the need for hospitalization. So what does one do in terms of self-care and monitoring, medical care, and being alert on the red flag signs when one may decide to consider extra treatment or upgrade to a hospital treatment? So the first and most important thing that all of you already know is the oxygen saturation. It is the single most important thing. And we all have a pulse oximeter at home. And we want to see that 95 and above on it as a reading. And I also want to show you the proning, the conscious proning, which is a very important and very useful, effective technique to keep your oxygen up when you're at home. So that is why I put a picture over there, because some people just lie flat on their belly on the bed and think that is what is proning, but that is not. We have to give some room for this chest over here to expand. So that is why we keep a pillow under your lower part of your belly and thighs, and also one pillow under your head and neck region and one under your feet, so that this area of the chest gets little room for deep breathing. So once you are lying in this posture, this I recommend should be done morning and evening, 2 times a day is enough. And this should be done for at least an hour in the morning and an hour in the evening. And every 10 minutes, 5 to 10 minutes that you're lying in this posture, if you take deep breaths, say 5 to 10 deep breaths every 5 to 10 minutes, as per your comfort, that is certainly going to be very useful because it expands all the areas of the lung which are not normally being used when we're breathing. So in this posture, all those nook and corners which have not been oxygenated and ventilated get nicely ventilated, and there is better exchange of oxygen, and therefore your oxygen levels are maintained above what we want to see, the 95 and above level. Also, sometimes there is a situation called happy hypoxia. This is a term which has come about now. The happy part of it is that maybe your oxygen goes down at some points in the day. And when you measure it, it's above 94, but there are times in the day when it's going down, but you're happily unaware of it. Now, how do we get to know about that? The best way is what we call a 6-minute walk test. Now, the 6 minute is just an arbitrary, reading which has come from a lot of studies that have been put together. But it can be done anywhere between 5 to 10 minutes for your convenience. You just have to walk at a normal pace in your room where you're isolated. So measure your oxygen saturation before and after. Comfortable walking for about 6 minutes, we say, because the person covers a distance of about half a kilometer walking in a normal pace in that time. So if your oxygen is maintained or it does not fall significantly, by significant fall, I mean 3 to 5%. So if you're at a 99 when you started and you fell to a 94, that becomes significant. At the same time, if you're at a 95 when you started and you fall even to a 93, 92, that becomes significant. So this gives us an idea of your oxygen reserve and also gives us some kind of a warning that this patient could go into a situation of dipping oxygen later on if the disease progresses. So we keep a more keen watch on such patients, especially when they enter their second week. So this conscious proning and 6-minute walk are two pillars for home care for your self-monitoring. And of course, you monitor your temperature, and we give paracetamol, Crocin, Dolo, all these Calpol, these are the brand names, which everybody has at home. So that is taken when there is fever, body ache or headache. And by fever, I mean 100 or above. So a 99, which people also consider fever, is not medically fever for us. Now, this chart that I've put is an example, and actually it came from a patient. So we advise patients to monitor, but there was this wonderful patient right at the beginning we had when the second wave started. And I thought this was a beautiful way of keeping track. And when this chart was given to us, at one glance, we knew what was the situation of the patient. So this is very convenient. 9 to 10 a.m., you put down your oxygen, 2 p.m., put down your oxygen. Then he does 6 p.m., 6-minute walk. So I took that learning from the patient. So it's 6 p.m. is your 6-minute walk, and you give me a reading before and after. And then this person would do his proning and also tell me if the oxygen improved after proning. So it gave me a very good idea that there was a dip with the 6-minute walk, but it improved with proning. And that was a very satisfactory thing for me that yes, this person is not decompensating, he's doing well. And then he did one in the night and then gave me a summary of his temperature, whether fever came that day or not. So at a glance, I could say day by day how the progress is happening. So if you're meticulous in keeping record, this is your self-monitoring, your self-discipline. It is a wonderful thing in home care because it really helps your treating physician. And of course, by treating physician, I mean, please sound off some medical person, preferably a family physician or some doctor you trust. And in this regard, it's better to go with somebody who's available to converse with through the day. Because in home care, a little bit of personal connect really helps, both psychologically and for better monitoring. So do be in touch with one doctor on WhatsApp, where you can share this chart at the end of the day. So this is, of course, the cornerstone, your oxygen, how you monitor it, and also with your proning, how you keep it satisfactory and always adequate. Now, of course, when somebody asks me, how do you treat a person in home care? Mostly the patient has to treat himself with these very basic things: a good diet, lot of hydration, because hydration keeps the fever from going out of control. About steam, a lot of people ask me. I don't suggest doing too much of steam. Doing it once a day is good enough, because too much can dry up your throat, your nasal passages, and actually sometimes worsen the cough. So keep it once a day for good antiviral effect. A good gargling, if you have cough or sore throat, it's useful. Walk, of course, for the 6-minute walk. But apart from that also, do keep walking time, and maybe every 2-3 hours, 3 to 4 hours, to keep yourself a little active, and also that helps boost mental energy. Breathing exercises, always welcome the alternate breathing pranayama. And of course, please read and watch interesting content. Now, this is again an experience I want to share, that those who refrain from watching the news, I mean, with all due respect to our media, but those patients who refrain from watching the COVID depressing news, and also those who stop doing, the WhatsApp University of medical knowledge, and refrained from a whole lot of videos which were, scaring and circulating, or their own research, and instead watched interesting, cheerful content. They heard a lot of music, had regular video conversations with their family and friends. They actually mentally did better. And that panic can create a lot of problems for both the patient and the treating physician if it's there. So we have to avoid that panic, that gloom component, that scare component, and refrain from becoming, modes of putting pressure on the doctor because of our own panic. And of course, mask is something that if you have a person from outside who is giving care to you, please at least wear a double mask when that person comes, or if somebody comes to collect a swab, or of course, at that time you have to lower it. And if somebody comes for a blood sample, so we can, at least protect ourselves and that person by use a mask at that time. So this is some of the simple home care tips which have worked, and sometimes just this is enough to get the patient off, especially in mild cases. Now comes the question of medicine. Now this is where we have seen a barrage of prescriptions and a lot of confusion. Now, of course, vitamins are supportive. We've said crocin is supportive. But these antivirals that we keep talking about, Fabiflu, then hydroxychloroquine, which came, went back, and now has come again in the guidelines. So this is for the third time that it has made a re-entry in the guidelines. And ivermectin, which is now part of the Indian COVID guidelines from ICMR. But still, most of the doctors will tell you, we don't know whether it works, the data is inadequate, it's too hyped, whatever. So the important thing here is that, yes, the evidence is not of high conviction. The evidence still says it may provide some help in reducing the viral load and maybe shorten the recovery time by a day or two, but that's it. There is nothing convincing there. However, having said that, we always give one antiviral. This is for us to feel, yes, there's a viral infection, we have an antiviral, we give one. And this is for the patient to feel that, yes, an antiviral was given. But there is no need to panic if your doctor did not write you an antiviral, or he wrote you one antiviral, or he wrote you two. Now, we've often seen a patient that I would write an ivermectin, he will hear of Fabiflu, he'll run to another doctor. The doctor will start Fabiflu after 5 days because the patient went that late. And by that time, there is no need to start an antiviral. There's no use starting an antiviral if you have gone beyond 4 to 5 days from your day one. That's why that day one is really important. So there is no need to worry about the antiviral. If it's given, it should be given, started within 5 days if it has to have any use. And any one which is written is absolutely fine. No one is better than the other, and there is no point giving 2 or 3 or adding in the prescription. So that should be, something which is very important to know, because that creates a lot of panic in the mind of the patients. Now, antibiotics, another, pressure prescription most of the time, absolutely not required. The only situation where I write an antibiotic, which by consensus with all the treating doctors over 1 month that we've learned, is if we think there is a secondary bacterial infection. Now, this we usually suspect if the sore throat component is very severe, especially when the person has pain swallowing and eating, or if the cough from day one is very phlegmy and is bringing out a lot of the phlegm and the mucus. That's the situation where I may add an azithromycin to the prescription, or if somebody else prefers a doxy or an amox, or even some Ceftum. These are the cephalosporin group, Ceftum or Ziffy, all these. One of them is given as a 5-day course. That's the only reason. Otherwise, there is absolutely no indication to give, and you need not worry if it's not on your prescription. Now, because you consult a second person thinking your first prescription could be better, it doesn't seem to have, dum in it, the second doctor would feel he has to add something because you've come to him because you're not satisfied. So he'll add one antibiotic or add an antiviral when there's really no need. So sometimes when the patient comes to me for a third opinion, I find on the prescription already a favipiravir, an ivermectin, an azithromycin, a doxycycline, four of them are going on. So all this is only going to cause a lot of indigestion and acidity for the patient. And he's going to get much more weakness and feel much worse. And for us, it is very important to hear from the patient, how are you feeling? That clinical feedback is what determines how we go forward with the treatment. So actually, the virus part is improving. Patient is improving, but he'll tell you, I'm feeling much worse today. I feel like throwing up. My stomach is bad. And then you're all confused whether the illness is progressing or he's reacting to these 4,4,5,5 strong medicines on his prescription. So it's really important that we go a little minimalistic on the first week with the vitamins, with the fever-reducing medicine, with one antiviral. If there is a need, one antibiotic for a secondary infection. And these anti-allergics which are there on the prescription, I personally think they are useful because they reduce the hyper airway irritation, which the patient has. So it settles the airway. It also gives a lot of expansion to the lungs, the quality of the air exchange. So I personally prefer to add this levocetrazine, montelukast, and Monter LC, Levo Monte. A lot of names are there. So that's good. So this is your first week. And most important thing that I've written at the bottom, to continue all the medicines for your comorbidities, like hypertension, BP, heart, if you've had a bypass, the medicines after that, or for diabetes. There have been patients who actually stopped those medicines. Said कि इतनी सारी दवाइयां लिख दी हैं डॉक्टर साहब ने तो हमने वो बंद कर दिया थोड़े दिन के लिए. And to tell you the truth, those were the medicines which were much more important. I wouldn't have minded if he stopped these. So let's not do that. The bottom line is what is supporting your comorbidities are the most important medicines during COVID. Now, having said that, what happens in the second week? So when the person finishes the 7 days of treatment, now this is where our greatest learning has happened. And I want to share that with you because I think this will really help if you can share it further with people who are positive or are suffering from COVID. So how does this disease progress? So now if you see this graph, the lowermost one, that's your typical mild asymptomatic person. So he will breeze through. By the time it's day 5, the symptoms will be more or less gone. and we have to do nothing for this person. And by day 5, day 7, it's all over and things are settled. So this is your mild, very mild asymptomatic patient. Now there will be a mild to moderate kind of a patient who will have more symptoms, maybe a fever touching 100, 101, a cough which is there, a lot of body pain, feeling of weakness, all this is there. But they usually settle down. They have a little persistence in the second week, but then it's nothing severe. Again, we do nothing in these patients. And this is the majority of patients. So I would say about 50-60% come in this category. Now there is this third group, which is mild to moderate to start with. And they seem to be improving between day 5 and day 7. But suddenly there's a worsening after day 7 in the second week. And then some of them could still come back to normal. Usually we see it at the end of 14 days. Or some of them would really progress at 10%, which would need hospitalization. Now, the million-dollar question is, how do we know who's going how? So that is why, day 8, that is beginning of the second week, and this is really a very good learning, we evaluate 3 things. First, are the symptoms persisting? The fever is persisting, cough is persisting, and in what way, to what degree? Second, how stable has the oxygen been? Has the person always maintained it above 94? Or there were situations where there was a dip to 93, 92, did a proning, it came up, or it did not come up, it took time to come up. So were there those moments when it did slip up a little? And then we do these basic blood tests. All is required is a CBC, CRP, and sugar, but your doctor may ask for more tests, D-dimer, other inflammatory markers, that's fine. Now, based on this alone, we decide what to do further. And this is where that balanced and informed decision comes in. So, if your fever and cough is persisting into the second week, there is no problem. In fact, we've always had patients where the fever goes on beyond the 3rd day, 4th day, there's panic. Please, doctor, do something and get my fever down. And that's when the steroids are prescribed too early and, all the panic prescription happens, antibiotics are shoved in. There is no problem if the fever is persisting into your second week. If the fever is low grade, it's a 99, less than 100, absolutely nothing to worry. If the cough is mild, there's just a little bit of phlegm once in a while, but mild cough, oxygen saturation is maintained. The blood tests are showing raised markers because they will. Let me say that in the second week, the markers, the CRP will be raised, your CBC will show a little bit of fall in your white blood cells, no problem. This is going to happen. Unless it is alarmingly raised, we do not worry by simply high readings. In such situations, nothing needs to be done. We just ask the person, continue monitoring your oxygen, and it's all sorted out in 1 week and the patient is out of it. Now, there will be some people where the fever is a little high, maybe 101, the cough is very phlegmy, it's still continuing. In such people, we are now recommending inhaled steroids. Not to go for the oral, but there is a simple inhaler of budesonide which is given. It's part of our guidelines and highly recommended. It really helps with the cough and also opens up the lung, removes the inflammation. If the fever is high, the cough is there, but at the same time, the oxygen saturation is a little lower than we'd want it to be. So we are seeing readings of 93, 92 on the chart, and we feel there is some degree of a dip. That's when we go for the oral steroids. Now, oral steroids are to be given only for 5 days in a low dose. And unfortunately, it is being rampantly prescribed right from the 3rd, 4th day, because it's very effective in controlling fever. So we are able to give a dramatic result to the patient in the 3rd day. But then by the time it's the 7th day, the person is worse. And at that time, the doctor has no other choice but to then severely bump up the dose of steroids. So the person is taking the steroid for 2 weeks. Then since it's on a bumped up dose, we can't stop it immediately. We have to taper it off. So then it becomes another week. So 3 to 4 weeks of unnecessary steroids happens. And as you know, that is a very big factor being discussed in the black fungus that we talk about. So most of the time, there is absolutely no need for steroids. And I've seen that 80% of the patients I've treated in home care actually did not require steroids. But some of them went for a second opinion and took the steroids. So I would like to say that also. And I had to stick to it that no, you don't require it. They took the steroid just because the CRP came high. Or, you know, some other LDH, ferritin, some marker they did that came high. The steroid was started. Most important is the clinical. We don't treat numbers or reports. We have to treat the patient. So if the person is improving and the fever is not high, the cough is not phlegmy, significant, the oxygen saturation, number one thing is normal and never dipped, oral steroids should not be used. Oral steroids come in only when the oxygen has been dipping. So that 92 to 95 bridge, these oral steroids help us in bringing the patient back. So that's where we use it. Of course, the fourth group is very high fever, oxygen dipping, severe cough. That's when we try to get a CT scan done to evaluate the lung damage. And that's the few patients where we consider hospitalization and oxygen delivery. Now, with this timely treatment and decision and the beginning of the second week, those small segment of patients who needed hospitalization, we can hospitalize them timely. That is, we can shift this hospitalization, which ends up happening after 10 days to before 10 days. And why is this crucial? Because drugs like this remdesivir and all that we keep talking about work only within that 10-day window. They don't work beyond that at all. And most of the patients are reaching the hospital after that window. So the right call taken in the beginning of the first week and segregating your patients based on these parameters, we can get the right people to the hospital at the right time and unnecessarily not trouble the remaining 80-90% who are doing well and will recover in home care alone. And here a word of caution about the oxygen. A lot of people have hoarded oxygen cylinders, not so much in Bombay, but if I had to tell you the situation in Delhi, almost every household I know probably has an oxygen cylinder or a concentrator. And they feel that, you know, it's not there in the hospital, so I'll, you know, tide over it at home. But there is a big caveat here that if you start oxygen at home, there is a complacency that I've started oxygen, but it will be nowhere near what is actually required when the oxygen levels start to dip below 90. You require more flow of oxygen, which is to the tune of 15 to 20, sometimes 30, 40 liters per hour, per minute. We even give it up to 60, 70. And what an oxygen concentrator at home or a cylinder does is only around 5 liters per minute. And cylinders give only 40% maximum oxygen. You have 21% in air. We've only increased it to 40%. And concentrators would go a little higher than that. And that also dips as we increase the flow rate. So you would be thinking that you're, you know, doing a great job giving the person oxygen, but actually you're not giving enough oxygen. Patient is deteriorating. A false complacency can come and actually a delay can come in hospitalization. So the oxygen therapy is not to be used instead of hospitalization. That should be really clear. It is only to buy that few hours if a bed is not available. And right now, thankfully, beds are available. That period we have gotten over. And now that kind of a situation we have been able to cross. So that should be importantly understood. So the whole idea here is in the second week to judiciously use the steroids and use inhaled where required, oral where required, and hospitalize timely so that the patient can recover fast in the hospital because we did not delay. Now, the most important thing here is panic component. This is where all the errors are happening, and this is what we have learned, that on the 8th day, once the reports come in, the symptoms are persisting, the panic element becomes so much that we've had patients terribly breathless because of anxiety. Oxygen normal, recovering, fever gone. But CRP came high. CRP mera 80 aa gaya, 100 aa gaya, panic, total breathlessness because of that. And there was actually no need to do anything. But because of that panic, all kinds of treatments were started, including blood thinners, steroids, antibiotics, everything was loaded. And actually none of it was required. But the panic of the patient puts the pressure on the doctor. And the doctor feels he has to do something. And that is where the second opinion, third opinions come, and drugs keep getting added on the prescriptions. Dosages of steroids keep getting increased. And that is what we have to avoid, because wrong decisions get made if there is this panic. So do not panic if you see numbers which are high. A person may be deteriorating with a CRP of 50, a person may be improving with a CRP of 100. There is no need to panic on numbers, and no need to go running for a CT scan, please, because the score hardly changes our decision. It is only advised in that group of patients with high fever, very phlegmy cough, and dipping oxygen. That's the only reason where we actually get a CT done when we are considering hospitalization. So panic has to be avoided is my, big learning, that a lot of things get disrupted because of this, everybody getting worried and panic. So going further, if the person has been fever free at the end of 10 days, up to 14 days, is declared as recovered, and there is no need to do a repeat RT-PCR. There have been instances of full recovery, no symptoms. The RT-PCR has been coming positive for weeks and weeks, and we don't know what to do because the society won't allow the maids back, and there is utter confusion. The office won't allow him to come, and all kinds of things. This can happen because of certain viral remnants integrating with our cellular machinery. Therefore, they can last for months. So the dictum now is you do not have to repeat an RT-PCR after your recovery has been certified by a doctor. There is no need to go and do an antibody test also, please. That is not going to tell us anything. You may have antibodies and we cannot gauge the level of protection. You may not have antibodies and still be protected. So it's a waste. And again, a number will come and create panic. There is no need to go and do a flurry of blood tests after recovery. Your markers may be high for weeks. And again, the number will create panic. So we don't want to create panic with numbers. That's the most important thing. And important thing post-recovery is actually how you get your health back instead of doing more and more and more tests. It's important that you resume your activities in a graded manner. Continue your breathing exercises, nutritional supplements. Keep a tab of your oxygen every 2 to 3 days. Don't kind of throw away the oximeter that, hey, it's all over. No, you'll keep a tab. And be in regular touch with your physician for 3 months so that any new symptom coming in, anything, you're able to inform your physician. And some of these symptoms are very natural. There is no need to worry. We have a lot of people calling us up, headache chal raha hai, energy levels are not coming back, I'm not getting my appetite back, my smell has not come back, my taste has not come back, I still feel feverish, and they record their temperature every day, it comes to 99 and there is severe panic. There is no problem. These are all part of post-COVID recovery and absolutely nothing to worry. Yes, we do not yet know a lot in this direction. We're still learning because we haven't seen that length and duration of post-COVID recovery in the second wave yet. So there have been instances where we were surprised at a heart attack which happened or a stroke that happened. But there is no way that you can keep on doing tests to know where it's going to happen. So it's about alert that you control your comorbidities, control your general health, bring back your general health, nurse yourself back with good diet, and keep yourself mentally stress-free. That is what is going to help you through in your post-COVID recovery period. And this can last up to 3 months, even more when we call it long COVID. Some people in the US and all who have seen the second wave have seen symptoms like this go on for 6 months. So that's called long COVID. That's a name that has come up. And now the recommendation is vaccination 3 months post-recovery, whether it is your first dose or second dose. So that is about the home care learnings that I wanted to share with you. And I really hope these learnings are useful in keeping yourself mentally stress-free, without panic, and doing the right thing at the right time. And there is absolutely no need for panic or any kind of taking any pressure. And that is where we have all learned as a group of doctors, whether it's through the NHA or through the Mumbai COVID mission group, we've all learned with every case. And that is where we're able to bring this to all of you. Now, of course, coming to the topic of the season, unfortunately, which is the black fungus. The fungus is not black. It's called black because it obstructs the blood vessels and the area supplied by the blood vessels becomes damaged, loses, dies off, so it appears black. So it's the blackish discoloration that has given the name. I think you're already hearing about a white fungus. I'll touch upon that also if anybody's interested. But now about this black fungus, why does it happen? And I'm asking this question because we have seen this is happening much, much more in India. We did not hear about this anywhere else in the world, actually. So that is the big concern. Why is it happening in India? Steroids were used everywhere, all over the world. But why is it happening here? And if you see on all news channels, the steroids are being blamed as the #1 cause. And I'm not going to say or exonerate steroids in any way, but it is a multi-play of factors which has resulted in this happening prominently in India. Most important here is the COVID variant strain. Now, we have seen that this variant strain is more